Good morning again, everyone. Welcome to the 2012 Everett v. Fox Student Case Competitions Finals Round. We have Team I with us this morning. Just want to remind our attendees to please silence all communication devices. I'm going to allow the team a few moments to introduce themselves, and then we'll go into our judges' introductions.
Hi, my name is Tamara Durr.
Nicole Williams.
And Jessica Jolly.
For the judges, we'll again start on this end of the table.
Jennifer Campbell Fitzgerald.
Denise Brooks Williams.
Good morning, Pam Sutton Wallace.
Good morning, Dale Oliver with HCA.
Good morning, Herb Buchanan. I pastor the largest congregation in Toledo.
Good morning, Yvonne Spence, Dignity Health.
Ken Page, Catholic Health Partners.
Thank you. Just a few reminders. The team will have 20 minutes for their presentation. Once you're ready, you'll state to the timekeeper that you're ready to start. Timekeeper is right over there. You'll receive a 5-minute warning prior to the end of your time. Immediately following the end of the presentation, there'll be a 10-minute question and answer session, and we'll have a 2-minute warning that will advise you prior to the end of your time. For our attendees, we want to remind that once the team has started, there'll be no movement in or out of the room until the presentation has been fully completed, including the question and answer session. Thank you.
Well, good morning once again. I'm Nicole Williams. These are my colleagues, Jessica Jolly and Tamara Durr, and we're Team I. We're ready to begin.
We would like to thank you for having us here today. Before we officially begin our presentation, we would like to conduct a small demonstration that will be representative of the proposed solutions we'll be offering today. So I would like you to take a moment to turn your attention to Jessica and Nicole. Jessica and Nicole are two accountability partners, Jessica being the patient, Nicole being the provider. Now, as these two accountability partners turn towards each other, palm facing forward, leaning in towards each other, really centering all their weight in the middle, keeping each other balanced, they're probably wondering the same things that you are. Can I really trust this accountability partner? Our team has been invited here today by you, Catholic Health Partners, to help you address the concerns of caring for the dual-eligible population of the Northwest region of Ohio. This is a population that has complex health concerns. The previous balancing activity was to give you an idea of what some of your patients and your providers are probably thinking. Patient, can I really trust my provider to help keep me centered and well? Provider, if I give this patient these resources, are they going to take them and use them to help keep themselves healthy and in balance? This brings us to why we're here today. We're going to help you address the challenges of coordinating care of the dual-eligible population by offering a solution of building trust with this population and developing a partnership, strong partnerships, that will help you to provide coordinated care with a touch of compassion. Finally, not only are we going to show you how to provide care for this population effectively, but we're going to show you how you can do it with a cost savings of $1.6 million, reduce your ED rates by 25%, your readmission rates by 26%, and your average length of stay to 4.5 days. But before we get into the details of our strategy, we want to take a moment to think about who the dual eligibles are. What makes this population so unique? Why are they so special? The dual eligibles are individuals who are beneficiaries of both Medicaid and Medicare. They're young and old. They have severe chronic conditions such as pulmonary disease, heart disease, cognitive conditions such as dementia and Alzheimer's, instances in which they can't get out of bed in the morning on their own because of disabilities, or be able to take long car rides to doctor's appointments because of debilitating arthritis. These situations often lead to issues of being isolated and loneliness. We think it's critical for us to understand these conditions in order to determine what type of care we can offer this population. So, what are our proposed solutions? What is this unique technique we're proposing that you implement? We propose that you start an accountable care organization titled the Centering Health Collaborative, CHC. Now, CHC will provide accountable care by centering and balancing your patients, much like Jessica and Nicole demonstrated earlier. We're going to show you how to do this with services such as transportation, care coordinators, as well as support groups and innovative technology such as the Emma.
The key question is, how does all of this impact Mercy Health System, and what should we do about it? with multiple policies coming into effect under Obama's Affordable Care Act, such as the Medicaid expansion and the CMS readmission reduction program, it is imperative that Mercy Health System assess its preparedness for these changes. Now, according to Medicare, Mercy Health System is currently operating at a 20% readmission rate. Now, as of October 1st of this year, hospitals across the nation will be financially penalized for excessive readmissions. Now, in addition to this financial risk, a Mercy Health System runs the risk of being operationally unprepared for the influx of nearly 10 million dual eligibles in the United States by 2024. Now, Mercy Health System is well on its way to being prepared for these changes that are coming down the pipe by having 50 patient-centered medical homes that are staffed with 170 clinicians, as well as having installed EPIC, electronic medical record, throughout the health system. Now, with the proposed solutions that we're going to discuss with you today, we will ensure that Mercy Health System is ready for these changes, as well as being ready for being able to center the health of the dual eligible population. Now, in order for Mercy Health System to actually achieve Catholic Health Partners' mission of extending the healing ministry of Jesus, and basically by improving the community in which the underserved and the poor are currently situated in, and of course by reducing its readmission rate, we're proposing that Mercy Health System enter into a unique and engaging accountability partnership with Aetna Health Plan as well as Buckeye Community Health Plan. And this partnership is called the Centering Health Collaborative. Now, what they're going to do is coordinate and manage the care of the dual eligible population by implementing the In-Balance Initiative, which is an initiative that will be focused on caring for the dual eligible population in a cost-effective way that will make sure that they're able to center and balance their health. Now, I want you to think back to the activity that Nicole and I performed earlier we were engaged in. And basically what we did was lean on one another for reliability and support. And that's exactly what we're proposing Mercy Health System does by entering and creating a steering committee that's composed of Mercy Health System, as well as the 2 health plans, as well as the Neighborhood Health Association, our neighboring federally qualified health centers, as well as, and most importantly, the patient. Now, what do these partners have to invest? Well, Mercy Health System will invest the 50 patient-centered medical homes in addition to EPIC, as well as community health workers and their training. Now, these community health workers will serve as patient advocates. They will also serve as a liaison between the community as well as the health system. And this is really important for building trust with the dual eligible population. Now, in regards to our health plans, they're going to provide EMA, or the Electronic Medical Management Assistance, to all patients. And we know that medication compliance is a huge issue for this population, and this will help the patients make sure that they're doing that and being compliant with their medications. Additionally, they will prepare or provide directors of care coordination who will oversee the direct activities of our 50 RN care coordinators. Now, one thing that's really unique about our partnership and steering committee is that we're going to call on our federally qualified health centers to provide social support services to our dual eligibles. These things include food security through the food pantry and providing daily meals to the dual eligible population, as well as providing transportation to the disabled. Now, most importantly, our patient, what do they have to invest? Well, they have to invest the willingness to participate and take charge of their health care as they move along their journey to balanced health.
Now, we've taken some time to discuss our accountable care organization, Centering Health Collaborative, CHC. Now we want to take some time to discuss the exact program that we're suggesting that you implement. It's our Imbalance Care Coordinated Initiative. Now, Imbalance has multiple components. We have our primary care centers. We have our specialists, which is really important to this population given their multiple health concerns. We also have our hospitals who will address any acute care concerns our population may have. And finally, we have our long-term care services. And that will primarily be focused on our home health services because we know that it's important not only for our patients to receive quality care, but quality care in the comfort of their own homes. Now at the top there, you can see our care team. Now this includes our physicians, our nurse practitioners, our community health workers, even our RN coordinators, anyone who has hands-on contact with the patient, making sure that they transition from level to care smoothly and appropriately, making sure we don't lose those patients in between the cracks. Now here at the bottom, we have our prevention and social services thread. Now this is threaded throughout our entire continuum of care to make sure that our patients are receiving the support services that they need. Now, I want to draw your attention to some of the core components of our imbalance initiative. It includes our community health workers. Now, these are on-the-ground soldiers. They're going door to door, making those phone calls, making those contacts with those patients, developing that trust and letting them know that we care. We also have our care coordinators, who we mentioned before. They're provided by the health plans. So not only does the health plan have a voice on the payment side of things, but they also have a voice on the patient provision care side of things. Finally, we have our PCMHs, as well as our centering health sessions, which we'll talk about a little more in detail later. And next, we have our psychiatrists, our mental health professionals. Now, they'll be co-located in the primary care physician offices, working alongside the PCPs. We know it's not only important for our patients to be balanced in their physical health, but centered in their mental health as well.
Now, we realize that all patients may not enter our initiative through primary care. So we came up with 3 methods to grab them and bring them into the fold. The first being physician referral. Physicians will identify their dual-eligible patients who are high utilizers. They'll tell them about the imbalance initiative, the benefits of joining, and really try to encourage them to do it so they can have better health. Our second method is by targeting dual eligibles in the ED. Community health workers will be stationed in EDs during peak utilization hours. When they see dual eligibles come in with non-acute symptoms such as colds or coughs, they'll sit down with them, educate them about the correct use of the ED, and redirect them to primary care resources. Now, of course, patients may decide to stay in the ED and continue on with their course of treatment, and that's fine. Should the situation ever occur again in the future, they now know that there are other alternatives besides an ED. And our third method is by contacting the dual eligibles. Health plans will use administrative data, such as claims information, to identify those dual eligibles who tend to have a higher utilization of services. They'll contact them directly by phone, tell them about the imbalance initiative, and really try to encourage them to join. We'll enroll patients over a 3-year period, bringing in 20% during the first year, an additional 30% during the second year, and another 40% during year 3. Now, once we've captured patients and we've brought them in, how do we keep them on the path to balance? Well, first we'll have RN care coordinators call patients and register them for open houses, telling them the benefits of attending and arranging for transportation if necessary. Patients will then attend open houses at their assigned patient-centered medical homes, where they'll meet and build a rapport with their care teams. Once these relationships have been established, patients will start to attend visits with their primary care physicians, as well as centering health sessions, which is based on a best practice where patients will come in groups of 20 to 25 and receive health education and social support.
Now, as Nicole mentioned, our patients will attend open houses at their assigned patient-centered medical homes. And this will serve as a way for them to be oriented to their homes away from homes. In addition, during these open houses, they'll be able to build a rapport with their care teams directly and learn about the benefits of patient-centered medical homes. They will also take part in individual and family health risk assessments. Now, one of the key features of patient-centered medical homes is having increased access. So for us to meet that requirement, we're going to have extended hours on Saturdays from 8 a.m. to 5 p.m. In addition to that, we will also have a nurse-ran or nurse practitioner-ran clinic that will operate Monday through Fridays from 5 p.m. to 9 p.m. Now, what about when patients can't schedule an appointment in advance? We're also going to have same-day appointments available as well, and that's to make sure that patients can have that continuity of care and see their own physician when they need to.
So what should our patients expect when they walk through the doors of their home? We have multiple qualities of our home, and 4 of them are going to be mentioned here. We have our health education. Now, this is an opportunity for our patients to engage in topics such as diabetes management, healthy weight, nutrition, physical activity, things that really apply to this population. We have the support group settings. Now, support group settings are to give them opportunity to engage and interact with individuals who are suffering from some of the same conditions that they deal with on a daily basis. This is also going to address that isolation piece that we mentioned earlier. Next, we have our checkups, which will be conducted by our primary care physicians as well as our mental health professional. And finally, we have our prevention piece. Now, the prevention piece is going to be wrapped throughout the entire home because we believe it's really important for us to be able to address the concerns of our population before their conditions worsen. Now, we've mentioned that many of our patients have multiple health concerns, and oftentimes with that comes multiple medications. So medication management is crucial to this population. We're proposing that you implement the EMA, which is the Electronic Medical Management Assistant. Now, this is a device that is placed in the patient's home by the health plans. It has blister packet medications, and at the time that the medication should be dispensed, the physicians are remotely controlling the device from the office, making sure that they're receiving the appropriate dosage as well as the appropriate type of medication. Now, this next slide is just to give you a glimpse of where our health centers are, Mercy Health, and the community health centers that we mentioned before. This shows you the green dots are the health centers and the community health centers are the blue dots. That creates easy access for our patients so they can receive those support services that they need.
So in order to provide long-term services to our patients, the Imbalance Initiative will utilize home health services. Dual eligibles do tend to be isolated and without transportation. So this is a way of providing both health and companionship to them. Now, home health is less restrictive for patients while allowing them to maintain a sense of independence. It's also more efficient than institutionalization. However, if patients do require care in a long-term setting, the Imbalanced Care team will work with them to identify long-term care facilities in the area and ensure that they have a smooth transition to those services. So if we've brought patients in and put them on a path to balance, how do we keep them in balance? We came up with several tools based on best practices which can be utilized by both clinicians and the patients. Patients will engage in shared decision-making with their physicians, which will empower them to make healthy choices, as well as having them surround themselves with a strong family support system. Nurse care coordinators and community health workers will call patients after discharge or appointments, just to make sure that they're doing okay and that all their questions have been answered. And they'll do that in addition to conducting home health visits. Clinicians will engage in tools such as the teach-back method and shared decision-making, in addition to motivational interviewing, which is used with those who are resistant to change. It helps them identify barriers to their compliance and set goals to overcome them. And for each medically necessary in-network visit that a patient attends, they will receive $25 on a prepaid debit card with the maximum set at $175. This is a tangible incentive for them to remain involved, and it also helps them out a little bit financially. And this is currently a program that the Buckeye Community Health Plan is doing with their ABD population. Now, in order to align care delivery with financial incentives, we want to eventually shift Mercy to a full capitation model. Now, right now, they're on a fee-for-service model for both inpatient and outpatient services, but we do want to move them to that full capitation model, where both clinicians and the health system will be paid on a per-member, per-month basis. In order to bridge the gap between the two, we want to institute a shared savings model for a period of time, with a managed fee-for-service system and shared savings amongst clinicians and the health system.
Now, as Nicole mentioned, shared savings will serve as an intermediary to achieving full capitation. So what does that mean for our Centering Health Collaborative? Well, the estimated $1.6 million that we've come up with or calculated will be equally distributed between Mercy Health System as well as our two health plans. Now, what about our clinicians? How do we incentivize them and want them to become a part of our initiative? So what we're proposing is that we would have our clinicians receive up to 80% of the shared savings, or Mercy's share of the savings. And that's due to the fact that most of the cost savings will directly be derived from the care that's delivered by our clinicians. So what are the financial implications of our Imbalance initiative? Well, we've estimated the total expenses to come to $2.3 million for these 3 years. But once we add in our cost savings, we come to the net cost savings of $1.6 million. Now, what about years 4 and 5 when we've attained full capitation? We've estimated $3.4 million that we will be able to save if the Imbalance initiative is carried out for those 2 years. Now, how do we measure our journey to balance? Well, we're recommending that the CHCR Collaborative, Centering Health Collaborative, utilizes several measures from NCQA and HEDIS. And these include quality of life, structural measures, screening and assessment, as well as substance use. And these are just a few examples of the metrics that will be measured. Now, we'd like to focus your attention to the key result area of care coordination. And that's because that's what's at the core of our initiative. And so if you look there, you can see that we have several metrics that are listed. The first being the percentage of patients that receive their vaccination for pneumonia, as well as those that have been seen within 60 days of discharge. Now, as you can see, Mercy Health System is currently in the red, but with our proposed solutions that we've discussed with you today, they'll be in the green.
In summary, we believe that the Imbalance initiative will help Mercy Health Systems tackle the challenges of the dual-eligible population. Issues such as fragmented health care, lack of accountability amongst payers and providers, and high costs will be addressed by our patient-centered medical homes, centering health collaborative, and financial alignment with that $1.6 million in cost savings. As Jessica and I demonstrated earlier, having an accountability partner is what really helps you stay in balance. By gaining the trust of patients, Mercy Health Systems will work with them as their accountability partner and help them achieve optimal health. With the successful implementation of this initiative, Mercy Health Systems will demonstrate that they have what it takes to handle complex populations, especially with the challenges occurring in healthcare. This will result in great outcomes for Mercy Health Systems, ranging from increased patient satisfaction to an improved reputation in their community. This concludes our presentation. We thank you for listening this morning. We now open the floor to any questions that you may have.
Hi, good morning.
Good morning.
Thank you for your presentation. I'd like to understand a little bit better how you're estimating your cost savings. Where are you achieving those cost savings? And also, I see in your financial statement that you estimate your expenses to be at $123,000. I'd like to understand how you're going to pay for your community health workers and what your assumptions were there.
Well, our assumptions were that we would be able to reduce our ER visits as well as our length of stay by 25% for each of those. And by doing that, we would be able to use the savings there to help pay for the training.
And that was based on a Vanguard demonstration that we found that was conducted in New Jersey, where they were able to actually receive some of the similar results working with a high-risk population.
So are you assuming your community health workers are already on board at Mercy, and you're just adding to their training, or are you paying for additional community health workers?
Right, we are paying for additional community health workers, and we've calculated those in the cost. So for each team, there will be health workers. It's a 1 to 25 ratio for our patient community health workers. If that makes any sense.
Can you bring that slide up, your financial
Sure.
I noticed in your in the percentage of patients that you plan on capturing that you have an increase from 20 to 30 to 40% over 3 years. Can you explain how you came to that conclusion, and also does it account for population growth rate, and particularly in the geriatric and disability communities for the duals? So if you can just speak on that a little bit. Sure.
Well, we wanted to bring patients in gradually just so we could see the results as we were implementing the initiative. And we believe that these numbers will be able to handle the influx that will come with the Medicaid expansion.
Okay. And given what we decided is that, based on some research that we conducted, the Medicaid dual eligible population is looking to expand to 14.5 million once this expansion is complete. And so we decided to account for that, we would increase our population by 10% once we hit that full capitation. The 20 to 40 to 50% was to just, again, give us that gradual increase to make sure that we're taking the time to see how this program is working, and then if there are any changes that need to be made to effectively serve this population, we would be able to do that. I believe you had a second part to your question.
Did it account for the population growth, the rate of growth?
We accounted for that 10% for that population. Okay. But as far as the Toledo, Ohio growth, what we've discussed is that given that the dual eligible population is typically immobile, for the most part they will remain there, low income, we would have those same individuals within that area. And not really thinking that we would have more influx of those individuals, because just the fact of that they're more centralized in the areas that they already are located, if that makes any sense.
A question. So one of your initial goals was to decrease length of stay to 4.5 from, that's part of, I'm sorry?
Oh, it was currently at 5.3.
Okay, and in short synopsis, how are you going to do that? And the assumption is that you have decreased ED visits, but we're also talking about those visits that would naturally go inpatient, right, not necessarily ED. So what was your thoughts behind that?
So we also assumed that our inpatient admissions would reduce as well. So we reduced that by 25% as well, and that's how we calculated it into our average length of stay.
And can you elaborate on your readmission strategy? How are you going to reduce them by 25%?
So we would
We figured that by having this initiative and having community health workers and nurse care coordinators talking to these patients and working with them after discharge, that any issues could be handled outside of the inpatient setting.
Right. And that goes into our continuum of care that we were discussing earlier. So making sure that we're not losing those patients in between the cracks. So those readmission rates that could be prevented, those are the readmissions that we're referring to. Those, making sure that we're coordinating with them after their discharge. You know, do you have your proper medication? Do you understand what it means when we say twice a day? Do you know how much you're supposed to be taking in that day, what your dosage is? Just making sure that we're really clear on the instructions to our patients and that they can trust us and make sure they follow through with those instructions.
Just one additional question. So you've got multiple agencies that you're coordinating to coordinate your care.
Exactly.
How are they linking their patient information? You referred to the health system having Epic,
Right.
but what is the system that's being utilized in the other areas and how will they coordinate?
Right. So we do have the federal, the FQHCs, and I believe it's the only piece that is not linked through the Epic system. And so with our steering committee, having those representatives on that committee, those monthly meetings that they'll be having, we'll be able to communicate what's going on in your system, how are things working with our patients, and then how can we best work to approach it at a different angle if need be. So those monthly meetings will be crucial to our ability to communicate how things are going and what progress we're making.
Just a question regarding your partners. Aetna and Buckeye are competitors in the local market, so how did you get them both to the table?
That's a good question. Well, we know that both health plans would like as much market share as possible. And so if they can work together and gain our market share, maybe possibly half and half, as opposed to not getting as much when working separately or one getting more than the other, then it seemed to be more of a win-win for each organization.
And also, just to add to that, I mean, by making sure that we're coordinating this care, we're going to be able to reduce the claims that they're going to have. So that's kind of how they're going to have that cost savings for them. So I think that adds to what you're saying.
So your plan does rely on a lot of coordination and cooperation, including a steering committee. I assume that's a real steering committee, not a virtual. How do you get all these folks to cooperate? Physicians, competing health plans? Is there a thought process, or are they all doing it just out of the goodness of their hearts?
Out of the goodness of their heart. Well, again, we do have those incentives going back.
Yeah, and that's true. So this is just a sample of the meeting agendas and some of the things that they would talk about. So we would want them to meet together face to face. And these would be the things that they would talk about, such as the clinical outcomes, the best practice, how are we engaging our patients. So bringing them together at that table and having a set agenda for them to work through is how we would be able to work through what we need to in terms of providing that direct care.
Everyone wants to see the same end goal. They want things to be better for the patient.
So this might be the first place in the country where you pull that off.
We'd like to think so.
Always the first for everything, right?
Well, and I have one more question. Have you seen, or did you all have any experience where you've had such a huge gain in responsiveness to patients participating with these care providers in the community? Because the assumption you're making is that all this education provided by these care partners in the community is going to bring these people in and decrease the readmission rate. So have you viewed any success models throughout the country where you could stand by and say, actually, this works someplace else versus coming up with a theory?
Well, it is based off, basically our entire model was based off of the demonstration with Vanguard Health System, and it was also Horizons Blue Cross Blue Shield of New Jersey. So they were able to achieve similar results with a 25% reduction in ER visits and 26% reduction in their inpatient admissions, or readmissions, excuse me. So it has proven to work, and they've also had increased patient satisfaction with the programs. And our Centering Health model comes from the Centering Health Institute, and you can go to their website as well. They also have an additional model for pregnancy as well that works and has proven to work for women who come together, and they have that support group as well.
Thank you
Thank
very
you
much.
very much.
Thank you.